welcome to WHO Africa media briefing, which is taking place in collaboration with the APO group. My name is Dr. Mary Stephen. First, some housekeeping. We have interpretation in both English and French. Please go to the globe icon at the bottom right-hand corner of your screen and select the language you would like to listen to the press conference in. Joining us this morning from Brazzaville is Dr. Matshidiso Moeti, the WHO Regional Director for Africa, and Dr. Moeti will introduce our other panelists.
Thank you, Mary. My warm greetings to our journalist colleagues and to everyone watching this press conference online. Bonjour à tout le monde. Today, we'll look at the risk of resurgence of COVID-19 cases in Africa, and also at the results of a recent worldwide WHO survey showing that a year into this pandemic, essential health services are still being significantly disrupted in many countries. I'm very pleased to welcome for this conversation Dr. Christian Owoo, the Ghana National COVID-19 Case Management Coordinator for Severe and Critical Diseases, who's also a senior lecturer at the University of Ghana Medical School, who will share with us his concerns for critical care services in the face of a possible resurgence. A warm welcome also to Dr. Kaushik Ramaiya, the General Secretary of the Tanzania Diabetes Association and NCD Alliance. Dr. Ramaiya will discuss what needs to be done to ensure that essential services are maintained. There have now been more than 4.5 million COVID-19 cases and 120,000 lives lost on the African continent. Overall, we're still seeing a plateau with a slight uptick, but the epidemic is trending upwards in 13 countries. We cannot be lulled into a false sense of security as the continent's case count appears relatively stable. The devastating surge of cases and deaths in India and increases in other regions of the world are clear signs of the risk of resurgence in African countries. The toxic mix driving this upsurge is present here in Africa. Adherence to preventive measures has weakened while mass gatherings and population movement have increased. A WHO analysis of 46 African countries finds that almost half are facing a high risk of experiencing a surge in cases. So now is not the time to let our guard down. I urge African countries to maintain a heightened sense of readiness, making sure that strong surveillance, clinical care, supply chain, and communications capacities are in place. We know that in times of crisis, it's often difficult for people to access essential services like safe deliveries and prevention and care for infectious and chronic diseases. To monitor these challenges and the mitigation strategies, WHO has conducted 2 surveys, first in July last year, in the middle of lockdowns in most countries, and subsequently between January and March 2021, when many countries were easing restrictions. The results of our recent survey show that of 40 African countries responding, 95% are still reporting disruptions to essential services. These latest figures show that the disruptions are persisting even in countries which have opened up after lockdowns. This is happening across all service areas, and most frequently those for mental health, immunization, and chronic diseases like diabetes and hypertension. Emergency, critical, and surgical interventions have been affected in 31% of countries. Health systems are suffering from workforce shortages, exacerbated by the repurposing of many staff to provide COVID-19 relief and the impact of COVID-19 infections among healthcare workers. Mistrust, fear, and financial difficulties are also resulting in fewer people accessing services. Most countries have put in place WHO-recommended policies to maintain essential health services, and half have allocated funding to support this work. Disruptions due to insufficient personal protective equipment and other health products have also decreased substantially, but we need to do more. Our healthcare workers need support, given their central role, and we must intensify community engagement to rebuild trust and confidence in healthcare services. Turning then to the COVID-19 vaccine rollout. On Tuesday, I met with the ministers of health in the African region to discuss key issues, particularly around expiring doses, supply shortages, vaccine safety, and misinformation. WHO is awaiting additional stability data from the Serum Institute of India to determine if the shelf life of AstraZeneca Covishield doses can be extended from 6 months to 9 months. For doses that have already expired, WHO is looking closely at the scientific, regulatory, logistical, and programmatic challenges and will issue a statement next week. We're encouraging countries to prioritize the first dose to reach more people rather than saving supplies for the second dose. It's imperative that the available doses are used as quickly as possible to protect people from severe disease and death due to COVID-19. We also urge countries that have vaccinated their highest risk groups and those that have pledged to share doses to quickly make supplies available to African countries that are ready to deploy vaccines. This will save lives and help bring about the end of this pandemic for everyone, everywhere. Suppliers play a critical role, both by prioritizing COVAX over the highest bidders and ensuring countries can contractually share doses with COVAX. We're seeing strong African solidarity in challenging circumstances. The Democratic Republic of the Congo, for example, recognizing that it would not be able to deploy all of its 1.7 million COVAX-funded doses before their expiry in June, has made 1.3 million doses available to countries that have not yet received doses or that have shown efficiency in their vaccination campaigns. Agreements for redistribution are now being finalized with the Central African Republic, Ghana, Senegal, and Togo, with shipments planned in the coming weeks. Finally, next Wednesday is Hand Hygiene Day. Frequent hand washing is among the top interventions to prevent COVID-19, diarrhea, and other diseases. We have seen adherence to preventive measures slipping across the region. So I call on individuals, leaders, and civil society groups to use this opportunity to reinvigorate and mobilize community to keep up good hand hygiene practices. This will have benefits far beyond COVID-19, along with wearing masks and practicing physical distancing to help in bringing an end to this pandemic. I thank you very much for joining us and look forward to our discussion.
Thank you, Dr. Moeti. Now we turn to Dr. Kristen. Can you please tell us about the impact of the COVID-19 pandemic on clinical and critical care services?
Thank you, and thank you, Dr. Moeti, for inviting me to participate in this discussion. The global impact of COVID-19 pandemic has been devastating for most, if not all, African countries, and it's still evolving. Africa, as Dr. Moeti has stated, has had its share of cases accumulating over 4.5 million, and sadly, we've lost over 120,000 Africans. We currently still have over 350,000 active cases in our continent, and almost 4,000 of them are critically ill. It is also very important not to lose sight of the impact of this disease on other non-COVID related diseases, which may even be much more bigger due to the disruption of healthcare delivery to these other entities. It is therefore important, as we see two waves go by, and seeing that the impact of the second wave was even much bigger than the first wave, and with the threat of a potential third wave staring at us as we see other countries in the world reeling from its impact on their healthcare delivery system. Even the most, even the biggest countries in Africa are actually having their health system being brought to the brink of collapse by this pandemic, whereas other African countries are now requiring both external material and human resources in containing the pandemic in their country. Major gains had been made in Africa in the last 2 decades, including in improvement in the management of communicable, non-communicable diseases, and acute care and critical care in our continent. But these are being rapidly lost in just over 1 year due to the massive repurposing of care and resources towards COVID-19 efforts. These resources would include specialized and critical healthcare workers, ICU capacity, oxygen therapy capacity and the ecosystem, essential equipment and medicines, and depleting funding from both our government and donor agencies for healthcare delivery. This has resulted in excess deaths from both COVID-related and non-COVID-related critical care diseases. And therefore, it has become eminent that as a third wave stares at us, that we plan to minimize or mitigate the impact of this. I have a few recommendations, broad recommendations towards this end. And these are currently being implemented by the Ghana National Case Management Team with the support of our Ministry of Health, our Ghana Health Service, WHO, and other partner agencies. One, it is important at this moment to monitor and reevaluate the impact of the 2 previous waves on our healthcare system, and especially in the management of patients who are severe and critically ill, not only with COVID-19, but with other diseases and surgical interventions. 2, there's the requirement or the need for active recruitment, training and retraining of healthcare workers, especially in the detection, prevention, and management of critical diseases in our facilities at all levels of care, regional, district, sub-district level, to make sure that we mitigate or reduce the need for repurposing of our limited human resources towards COVID-19. We would need to replenish the logistics and resources that have been lost in the 2 previous waves in our facilities while we prepare for a potential third wave. There is the need for rapid expansion of our oxygen capacity and oxygen ecosystem, as well as critical care capacity and our vaccination efforts as a continent. There will be the need for reorganizing and strengthening our healthcare delivery systems aimed at improving care for patients who are presenting with severe and critical COVID-19 while preserving the quality of care for non-COVID-19 diseases who are presenting with emergency and critical diseases. And then finally, we would need to continue to strengthen our existing collaborations between African countries, between our countries and WHO and other agencies, and between our health sector and other sectors in our country, with the aim of maximizing our resources, human, material, financial, while hoping to minimize the impact of a potential third wave. Thank you.
Thank you, Dr. Kristen. Now we will turn to Dr. Ramaiya. Please tell us about the burden of non-communicable diseases and the impact on the COVID-19 pandemic.
Yeah, thank you to Dr. Moeti and for WHO Afro for giving me this opportunity to be present on this panel. I'll be discussing from 2 viewpoints. One is from the viewpoint of the people with the diseases, with NCDs and diabetes. And the second thing from the viewpoint of a clinician managing these patients who come with the comorbidities. So first of all, talking from the patient's perspective, so people with the diseases perspective, I think with the COVID, I think there were 4 major factors which caused limitations of the access to treatment. One was the initial fright and the fear of going to a health facility. As a result, many of these people with the non-communicable disease stayed at home because they were worried that going to a health facility, they'll get infected, and infection control, if it's not appropriate, they'll also get an infection. So there was a lot of I would say, mass media and a lot of issues being brought about that if you go, you will die, and those are the major bottlenecks were there. So many of these people with the non-communicable disease stayed at home for a longer period of time, not accessing the health facility, and then they were dividing their doses. So the doses they were supposed to take for a good control of the blood glucose or blood pressure or cardiac conditions, those medications were overstretched over a period of time, and their chances of getting complications due to the uncontrolled diabetes or hypertension or cardiac diseases were extremely high. Second thing was the stigma. There was initially a stigma. So if you had somebody in the family who had COVID, then that family and that house was sort of stigmatized, and nobody would go there, not even a relative or anybody would go them to support. So there was a question of stigma, and how do you remove the stigma? Third thing was the cost of going to a facility if the facility was far away providing COVID. So if you had somebody within the family going with a COVID condition, and if you had to go to a facility, then the question was, how do you access that facility based on the services available? And finally, it was the overall control, because within our region, I think if you look at diabetes or hypertension, for every diagnosed diabetes, there are 2 to 3 who are not diagnosed in the community. Similarly, for many with hypertension, there are many in the community who are not diagnosed, or those who are diagnosed, they are very poorly controlled. So you find that these are the individuals who are very, very susceptible to this condition. Talking from the perspective of a health facility and within the health system itself, I think initially it came as a shock. And when it came as a shock, it was like it is a rapid reaction of what we could do to contain the situation. And to contain the situation, one was the PPE, taking care of the people with providing the services, the healthcare providers themselves. Second thing, managing these conditions. And most of the comorbidities with the COVID which came in were related to those who had uncontrolled diabetes, who had uncontrolled hypertension, uncontrolled underlying cardiac conditions, or uncontrolled cancer, or those who were on chemotherapy. So managing all those conditions was a major challenge. There were no specific protocols of care. And giving an example of somebody who coming with diabetes who is adequately controlled with oral hypoglycemic agents, with COVID comorbidity, you find that the blood glucoses go beyond 20 and 30 millimoles, and you could no longer control with oral hypoglycemic agents. So your treatment strategy had to change. And that change of the strategy entailed this individual to provide insulin to this person who had COVID together with uncontrolled diabetes. So there were challenges in protocols of care, there were challenges in managing these patients, and there were challenges in coming to a right diagnosis. Similarly, what you find that the supply chain depending on what you require at what level of the facility was a challenge. So if somebody goes to a primary care and if he has a very high blood glucose and there is no insulin there, then this person has to be referred. And when he has to be referred and if he has got COVID, then you're talking of infection prevention and control. So how do you basically bring the care down to the lower levels of care? So those are the other challenges which we faced. Based on the experience we have had in Tanzania, we were fortunate that initially during the first wave which we had, we also, as a Tanzania Diabetes Association, we had basically got support from the World Diabetes Foundation, and we had written up a proposal which was basically dissemination in the city of Dar es Salaam. And we looked at the 4 targets. One, we said we need to train healthcare providers at different levels with an acute care training. And this acute care training would consist of providing people with enough knowledge and diagnostics and protocols of care for managing acute diabetes ketoacidosis or acute hypoglycemia, acute heart failures, excessive pressures, blood pressures, and any other electrolytic or fluid imbalances which they had. 2, IPC training was a core component of this training which was taking place. 2 was the community sensitization. How do we sensitize the community and ensure that those people They should not be stigmatized, but they should be brought to the facility. They could be managed, and if they are at home, how do you manage them? Third was providing supply chain so that at a primary care, you could provide the care and the treatment which is required. And finally, overall, strengthening the health system to see that whether you can provide a mobile outreach service to the communities which are very far away from the main facility and providing them continuum of care. So those were the challenges and those were the interventions which we did. So if we are to move forward, I think currently probably the community is aware, but then still there's a certain degree of stigma, and community sensitization is very important. As my colleague from Ghana mentioned, I think training of the acute care, and we should not be talking about acute care per se for only healthcare providers. We are talking of training acute care teams, because even a watchman at a facility is the one who receives a person who has got COVID. So he should know whether this is basically where should he go? Should he go into isolation or where should he go? Similarly, different levels of non-healthcare providers at the facility should also be trained. So we should be talking of a model of an acute care teams, which are basically healthcare providers, paramedical staff, and non-medical staff who could be trained to react to these conditions. Thank you very much.
Thank you, Dr. Ramaiya. Now that you have heard from all our panelists, it is time to ask your question. To do this, please use the question and answer function on the Zoom application. Tell us your name and the name of the media organization you represent. On hand, we have Dr. Nsenga Ngoy, who is the incident for COVID-19, and Dr. Atuibe Fiona, who is the vaccine introduction officer, to answer some of your questions. François, can you please explain in French?
Bonjour, merci de vous être connecté. Donc, un petit rappel pour poser vos questions. Merci d'utiliser la fonction Q&A qui est disponible dans les fonctions de Zoom.
Okay, thank you. So we are going to start our questions now. Nita, are you ready to ask your question? Right?
Yes, I'm here.
Okay,
good afternoon, everyone from Nairobi. I have two questions, both of which are linked to the situation in India. What lessons can Africa learn and implement right now as we witness the horrifying scenes coming from India? I mean, could we see the same scenario playing out across the continent here? And my second question is, if I may, what impact is India's export ban on the AstraZeneca Covishield vaccine having on the ground in Africa? And what measures can countries take to deal with this ban? Thank you.
Dr. Moeti, I pass this question to you first, and Dr. Ngoy will complement.
Yes, thank you very much. Of course, the situation in India, the explosive growth in cases and deaths is very sad to observe. And I think it's very correct for us to look at the situation in Africa and see what we can learn about it and how we can better prepare to contain any upsurge of cases in Africa. I think what we have observed is that part of the drive upwards was due, of course, to religious ceremonies, gatherings. So it was essentially around mass gatherings of a religious nature. And we know that there has also been election activities which lead to mass gatherings in India. And we've understood that there's also a variant which is now circulating, which is causing difficulties then in terms of its transmissibility. And I imagine that, like in many countries, as I said in my statement, there probably has been a dropping off of the observation by the population of the masking, physical distancing, and hand washing measures. I think the lesson that we can learn in Africa, one is to anticipate that such a wave is possible in different countries, and to really look at what are some of the driving factors. So countries that are going to have elections, activities where mass gatherings is going to occur should be particularly on the lookout. There's been a lot of debate in African countries about religious activities. In some, religious leaders are concerned that after a year, the kind of religious worship that people are used to is still not being taken up. I'm afraid it's still very necessary to sustain some of the measures of keeping distances. And as we have said many times before, to use data, to use information about the number of cases, the trends on as localized level as possible around adjusting these measures. Most importantly is to support the population, to reinvigorate, in fact, the interventions with people. We're seeing in African countries more and more of a drop-off in the wearing of masks, particularly. I've seen data from one country where the proportion of people not wearing masks has gone up to almost 80%, starting at about 17% in the earlier parts of the pandemic. And the proportion of people estimated to be wearing their mask correctly is even less than 10%. So this is going to be a problem in terms of heightening the risk. So we need to fight against this fatigue, fight against the sense of being invincible. I've heard quotations from people in African countries indicating this is not a problem for us. It's something that's happening somewhere very far away. No, we have seen increases in cases. We've seen waves in many countries on the African continent. So it's really a matter of sustaining these measures, both on the public health side. So we need to also sustain the public health work of testing, identifying cases, contacts, and urging the isolation of these cases. I'm concerned that in about 31 of the 47 countries in the African region, the testing rate is at less than the 10 per 10,000 recommended by WHO recently. So we have to support our governments to sustain two, if you like, features of action. One, around sustaining the public health measures, including testing. And here I would urge the use of rapid diagnostic tests, antigen rapid diagnostic tests. We've announced to our member states that we have a stock at the international level with WHO and partners, which is being underutilized. So the demand for these RDTs is less than we would like. We would encourage our countries to sustain their testing for public health measures, and then to intensify the interventions, communication with the population. At the end of the day, in addition to the formal statements by political leaders on the television, we have to get at people at the grassroots level. We have to make sure that the right information, the right encouragement, and the right support is reaching people through the networks that they trust, through those who carry messages that they believe, through the religious leaders, the community leaders, the women's leaders, youth groups, social media networks of young people. All of these should help us to disseminate the right information to help people to sustain these measures and to keep what's happening in India from happening in Africa. What is the impact of the export ban? Of course, the work that we are involved in as WHO through COVAX has depended very much on the Serum Institute of India as a producer and a supplier of the vaccines that are being rolled out on the African continent. So it is very understandable that a country going through the kind of situation India is facing while producing vaccines for much of the world will seek to use the vaccines to address their own crisis. So we are very concerned about the delays that are coming in the availability of vaccines. We had advised our countries to cover as many people as possible as far as the first doses are concerned. So we'll have to see what can be done to obtain supplies, other supplies, so that countries can be able to provide the second dose. And then at the same time, we're advising them very strongly then to replan, to use this pause as an opportunity to tighten the planning so that whatever dose of vaccine they can obtain can be rolled out and used most efficiently to have the optimum impact.
Thank you, Dr. Moeti. Dr. Owoo, I'll come back to you. Let's go to Sarah now. Sarah Javi.
Thank you.
Go live.
Yes, thank you. Can you please discuss the motivations behind why DRC has returned 1.3 million doses to COVAX? Is it because the government is still concerned about blood clots, or because there isn't the capacity to roll out the doses? And how much of a role does vaccine hesitancy by the population in DRC play in this decision?
Thank you, Sarah. Dr. Moeti, do you want to go first, and then Fiona can complement?
Yes, I'll go first and briefly. You know, the government of the DRC recognized the fact that they would not be able to deliver to the population all the doses of vaccine that they have received before they then announced the expiry date of these vaccines. And we think it's a combination of factors. One, there is certainly, and there has been a strong level of vaccine hesitancy in the population in the DRC. And then secondly, it was simply then the capacity to administer the vaccines in a country like the DRC, where, as you know, there are gaps in the capacity in the healthcare system. So we think it was extremely wise of the government to make this estimation, and it was very generous of them then to offer to share these vaccine doses with other countries that can be able to utilize them. So Fiona, you might want to supplement this response.
Thank you very much, Dr. Moeti, and thanks, Mary. And now I think Dr. Moeti has answered this question really well, but we want to make sure that the DRC is seen as an exceptional case. Given the volumes that were in question, we also remember that DRC paused for about 6 weeks the introduction of this vaccine because they were waiting for information from the European Medicines Agency and the Global Advisory Committee on Vaccine Safety from the World Health Organization. However, as we know that these doses have 6 months expiry, any amount of time that we lose on a vaccine with these vaccines, we lose time. So they did do a great job in identifying that the delay that was there, including, but also the rate of rollout. So far, the country is has rolled out only about 1,000 doses. That is such a low rate, and it was good that they did identify this and came out to call this out. As Dr. Moeti says, this was quite generous of them, and we think this was highly commendable. But again, we want to ensure that no doses go to waste, and we stand ready to support all countries that are concerned with the absorption rates of their vaccines, and this is what we are also doing with the DRC doses. Over.
Thank you, Dr. Fiona. And now to you, Elizabeth Mera from Daily Nation.
Thank you, Mary. My name is Elizabeth Mera. I'm a health journalist with Nation Media Group here in Nairobi. My question has partly been answered by Dr. Moeti, but I'd like to just make a follow-up on the Indian case. Of course, we know that the African continent shares a number of characteristics with India, and we are currently experiencing COVID fatigue coupled with low vaccination and the shortage of vaccines. So what does the Indian situation portend for Africa? And are there plans put in place by WHO to ensure that the continent does not find itself in a similar situation? Thank you.
Thank you, Elizabeth. Dr. Moeti, you go first, and then Dr. Ngoi just come in immediately after Dr. Moeti.
Okay, yes. As I said, we are very much supporting the governments to work in two tracks and wishing to lay emphasis on the importance of both. We have seen, first on the part of the population, as I said, but also the reality of stretching the capacities and attention at the government levels in the health systems between delivering vaccines and sustaining the prevention public health measures, that both of these have to be sustained. We've also seen a slight increase in the case fatality rate. I think our colleague who discussed, Dr. Owoo, was very much touched on the issue of acute care, the facilities that need to be increased in countries, and the urgency of making sure that supplies of oxygen, for example, oxygen concentrators are made available, are increased in African countries. So what we are doing as WHO is to continue to advise countries to work in terms of the public health measures, very much the community and public education, supporting people to be able to continue with the prevention measures that they have to take. At the same time, encourage the uptake of vaccine where it is available, and it has been available in some countries. Some countries I'd like to emphasize, such as Ghana, did a very good job of the rollout of their vaccines, so the possibility is there. We're encouraging countries to redouble their efforts in the micro-planning, the calculations and use of data in terms of targeting, making sure that they're mobilizing the numbers of healthcare workers that are needed for the vaccination campaigns, ensuring as well that they carry out simulations, put in place and sharpen their logistics. So in other words, what we're advising is first, sharpen, sustain the public health measures, avoid mass gatherings for various reasons. We know the number of the countries that are going to have campaigns, to have elections coming up. They need to really take the decisions to manage this in ways that minimize mass gatherings. And where we know that mass gatherings might be available, we're advising them that to anticipate and to sharpen the public health measures, and then to help people do their part to improve capacity for treatment, so that when people are ill, they do not die. We keep the case fatality rate as low as possible.
Thank you, Dr. Moeti. Dr. Ngoy?
Sorry, thank you, Mary, and thank you, Elizabeth, for the question. First of all, I think, Elizabeth, you're absolutely right. Sociologically, India is very close to Africa, to many African countries. So there is no valid epidemiological reason to think that what is happening in India cannot happen to Africa. So that's the fact, and you're right on that. So as African, we should not count on our gene or sun to protect us. So we have to work ourselves to prevent and protect our countries and our communities. So at WHO level, at least at the IMS, what we call incident management level, the team, what we've done actually from the beginning, this was the objective, is to avoid Africa going through what we are seeing in other countries. So far, it doesn't happen, but again, it doesn't mean that it cannot happen. So what have we done, at least for these resurgences? As a WHO in Afro region, again, first of all, we have drafted what we call the guidance on resurgence. It is a document that guides countries in terms of how do you recognize in time or timely the resurgence, and what action do you take when you recognize it and when you see that you are already in resurgence. What could be the actions, the public health measures, but also at the health system level? That's one. Then the second one, what we're doing, again, learning from what is happening in India, we see that the health system is overwhelmed completely. I mean, not completely, but at least the ICU ward, most of them are overwhelmed. So we need also to start preparing countries in expanding capacity, our capacity in taking care or providing care for critically ill patients. This we are doing with countries by mapping the capacity that we have, including the capacity in producing oxygen and providing oxygen to critically ill patients. That's the second. Now, the third one, despite all our preparedness at Africa level, we have to be also honest with ourselves. Maybe we can miss something. So we want to have kind of lesson learning from our colleague in the Sierra region, I mean in India, but also in the Sierra WHO region. Those are the actions that at IMS we are taking in terms of trying to get ourselves ready and guide countries appropriately to prevent what you are seeing in India to happen. But that said, That said, at WHO level, we can write whatever guidance or how many guidance we want and provide how many technical support and technical advice to countries. But if it's not implemented at country level, we might not see the impact of it in our country. You know, we might end up seeing what we don't want to see in Africa happening in Africa, that one. But even at country level, even if at national level, the national authorities, they take measures that they can put in place, they expand capacities as we're advising them. But if at community level, at individual level, we're also taking it on ourselves to prevent that the transmissions get out of hand, we might see what is happening in India, happening in some of our countries. So that's why there is regional responsibility, our all as a region, as a country responsibility. There is national responsibility, but there is also an individual responsibility, which is very important. Thank you very much, Mary.
Thank you, Dr. Ngoy. Dr. Christian, do you want to complement from the critical care perspective?
Can you please repeat your question?
Yes, complement on the how do we prevent what's happening in India from the critical care perspective, the question from Elizabeth.
Yes, so thank you very much. Most of the comments made on the lessons we've learned from India, there's the social and cultural behaviors and what is happening with respect to Africa at the moment are very, very comparable. We have always lagged behind the rest of the world in the African region in the arrival of cases and then the peaking of our waves. So, and we can remember what happened with both the first and the second wave, where mostly when we're having the peak or in other regions, we basically think it's not going to come to Africa, but it did come. Now, India has a lot more bigger reserve and resources for critical care. And then just 4 weeks ago, they were actually much better than most part of the world. And what has happened in India and happening in some parts of the Americas has actually evolved in a period of weeks, not months. So it is important that we may not have months at our disposal in preparing for the threat of an imminent third wave. In Ghana at the moment, we are actively, during the little lull from our second wave, in our regions, all 16 regions, so I'm currently in actually one of the regions, basically preparing our capacity, improving our capacity, looking at the gaps that existed in both the first and second wave, having discussions on increasing oxygen ecosystem. WHO had been very helpful in providing some oxygen concentrators, which we've distributed in a lot of our facilities. And with the support of our government, we are wrapping up training of acute care training, critical care training, even at lower levels where you do not have ICU doctors and nurses available. Now, it is important to do that now because it is almost impossible to do it in the middle of a pandemic, as we will all have found out during both the first and second wave. It is impossible to do appropriate redistribution of human resources based on objective assessment of our system. So what we are doing now is actually assessing our system, doing a needs assessment, mapping up where the lags in our system are, and basically planning the redistribution of not only material resources, but human resources, while we train quite rapidly to fill that gap. It is important for African countries to learn this lesson now because our health system were not as resilient as most other health systems. But it's also important to reduce the importation of COVID-19 new cases and new variants into Africa. Because if the numbers keep increasing, there will be a point at which, irrespective of your efforts at increasing your capacity, you will still be overwhelmed. And one of the lessons we're learning from critical care is that in the last 6 going to 7 weeks since Ghana started vaccinating, the proportion of patients who are presenting to ICUs with severe and critical diseases that had been vaccinated are rather much lower than those who have not been vaccinated. In the 2 biggest centers where I've been involved in caring for critically ill patients, since we started vaccination, we've not lost a single vaccinated patient, even though we have had a few who came to ICU. They have also had them gone. Whereas we still have significant mortality from those who were not vaccinated. Sharing of this knowledge is important in African countries. Research and sharing of knowledge is going to be a massive part of reducing the vaccine hesitancy, especially in African countries. We are working collaboratively with other African countries in making sure that this evidence are put out there to encourage efficient distribution of vaccines to arm.
Thank you, Dr. Kristen. The next question is coming to you, Fiona. This is from Peter from BBC. He's asking what is the reason behind the low vaccination uptake in Africa? What would you say is the issue? Is it the infrastructure to vaccinate health workers, or the lack of health workers for the vaccination campaigns? And secondly, have you been in touch with South Sudan and Malawi and other affected countries on the AstraZeneca doses that were meant to expire by 13th of April? There were reports from Malawi saying the doses were put off cold storage, so it cannot be salvaged. Do you know whether this has happened in other countries, or the vaccines, are they safely stored? Fiona, please.
Thank you very much, Mary, and thanks, Peter, for that question. So on the slow pace of rollout of vaccines, indeed, Africa has rolled out over 50% of the vaccines that have been received on the continent so far. So we need to give it up to the continent, much as it's not the pace at which we would have expected, but at least that has happened. So many countries have not been able to prepare adequately before the vaccines arrive in the country. And that is one of the reasons we are seeing a slow pace of rollout. But also we know that due to rumors and the myths and misinformation that came especially around the safety, also with around concerns around the variants, the spread of variants, we had low levels in this vaccine, and hesitancy has really been seen to contribute to the slow pace of rollout. In some countries, we've seen the lack of operational funding, or even when the funds are available at national level, the countries have not been very quick in disbursing these funds to the subnational levels, and that also contributes to the low uptake. But also we are having limited data especially from the rural places up country. It is easier to get this information when it's at national level, because most of these systems are now internet-based. So we are having issues with getting that data. We know actually for sure that more vaccines have been given than we receive in our daily update on the live dashboard that WHO hosts. When it comes to the expired doses, yes, WHO is in touch with all these countries because we do have a footprint in most of them, indeed, basically all our member states, and we are working to map the expired doses in all the countries that received them, with the exception of Togo and Gambia, who let us know that they had utilized all the vaccines by the date of expiry. But I must mention that WHO is reviewing scientific, regulatory, and logistical and programmatic challenges, and a statement is expected next week. Information from the Serum Institute of India to the World Health Organization pre-qualification department is expected tomorrow, the 30th of April. And from here, we should be able to release guidance about these vaccines next week. But I would want to stress one point, that an extension of shelf life is about the stability and potency of the vaccine during the stated time frame, and does not affect the safety of the vaccine in any way. So that's important to know, that what we are looking for now, all that evidence and data that we are waiting for from the Serum Institute of India, is information that will assure us about the potency and stability of the vaccine. Then thereafter, we shall get to each individual country and see how they have stored these doses. Yes, you're right. Malawi had removed these out of the cold chain, and these are vaccines that cannot be used. For example, we are working with the countries to help them to see how to destroy this vaccine. We have a waste management protocol for all vaccines, and we shall do the same using those SOPs for the COVID vaccine for countries where we think they should be destroyed. But let's wait for the guidance that should be out as early as Monday for these other countries. And we are in touch with all the countries affected. Over.
Thank you, Dr. Fiona. Now I will turn live to Paul Adepoju. Please ask your question.
Thank you very much. So my question is has to do with the recently established COVID-19 mRNA vaccine technology transfer hub by WHO to scale up global manufacturing. I'd like to know if Africa is involved, is leveraging on this transfer hub currently, or what the plan is towards being partaker of these initiatives. Thank you very much.
Thank you, Paul. Dr. Moeti?
I think I'll refer this question to Fiona, but just say that WHO is leading this work. I'm aware that our colleague, Dr. Sumia, is doing that work. And I think this is something that's relatively recently been established. So we will have to, of course, see how to promote and mobilize for African countries to be involved in this work as well, because we would very much like African countries to be part of this. I know that there are a couple of African countries that have indicated an interest when the time comes to be sites of local production of these vaccines. I know that Rwanda is one of these countries. So Fiona, perhaps you might be able to provide more definite information on this, but certainly the intention is to engage Africa in this work.
No, you're very right, Dr. Moeti. The discussions are ongoing, and that the discussions have started, and Africa will be part of this initiative once this starts. But some countries have indeed expressed interest, and at global level, this work is ongoing. So we shall, of course, update you as the situation evolves. Over.
Thank you, Dr. Fiona. Our next question is from Duncan from Reuters. Given the devastation in India, it's highly unlikely the government will lift restriction on vaccine exports. Does the WHO Africa have a plan B to get vaccine to African countries in coming weeks or months? Because J&J is not coming to Q3 earliest. Fiona, please.
Yes, indeed, it is quite devastating for us and for everybody, but we must also, again, exercise a lot of understanding and empathy with the government of India because of what they are going through. So WHO is currently assessing the impact of these delays on all African countries, and because the majority of countries are actually using the COVAX doses, and most of them will reach that 12-week gap between the two doses in May, at the end of May or mid-June, and also mostly in July. So all options to widen the supply are being explored, including dose sharing. We have had countries like France, countries like Canada, the US have promised to do dose sharing, Sweden. So we are looking forward to, COVAX facility is having intense conversations to increase the rate at which the speed at which these doses can be shared. But also we also call upon countries that have extra doses to do their part, and also suppliers with additional capacity to ramp up the capacity. All these conversations are ongoing. And also to the review of the documents for the Sinopharm and Sinovac, the Chinese-made vaccines, is taking place this week, and we hope to have maybe positive feedback by early next week. And if we have more vaccines that have been approved for WHO pre-qualification, we know that more of these candidates then enter into our continent without any further issues. So we are really exploring all that can be done.
Okay, thank you, Dr. Fiona. The next question is still on vaccine. Biotech has said it's discussing the possibility of producing its vaccine in Africa. Do you have any knowledge of that in terms of which country and which manufacturer? And then secondly, do you have an update on how the wave of COVID-19 being experienced in India is impacting on Africa's COVAX delivery? Dr. Fiona, please.
Mary, I think the last one has been answered. Yes, there's been a clear impact on not only vaccines, but actually the supply chain for most of the products that we get, that the whole world gets from India. So definitely the COVID-19 vaccines could not be spared, especially given the fact that the country also needs these vaccines. And that's why I said we need to exercise maximum understanding and empathy with the people of India. So this has greatly affected us because India has closed off shipments, not only through the COVAX facility, but also for countries that had bilateral agreements with the manufacturer, which is understandable because they need to save their populations first. For Pfizer-BioNTech, I must say that for the COVID-19 vaccines, it is too late for Africa right now at this point in time to say in 2021 or 2022, we shall have vaccines manufactured on the continent, for at least not to cover the COVID pandemic for the next 1 or 2 years. The countries are yet to express their interest, but after expression of interest, the scientists, WHO together with the African Union, will sit down and evaluate which countries have the right infrastructure or could be helped to develop this manufacturing capacity or to ramp up what they already have and expand what they have. But for now, no, we do not know which country will be able to start this. Over.
Thank you, Dr. Fiona. And the next question is to you, Dr. Chris. The issue of a waiver on COVID vaccine patents is mounting. What is Ghana's position on this? And to what extent is this proposal key to assuring global access to vaccine and to reaching a certain global herd immunity? Dr. Chris, please.
So thank you. There's been significant commitment from our government in Ghana, and specifically from the president of Ghana, at putting our efforts in ensuring that we procure enough vaccines. We would actually be due our second dose for those who started at the beginning of March, from the end of this month to the end of May. And there's a lot of effort actually going into that. Secondly, our government has committed towards local production of vaccines, and there are discussions ongoing. A number of our local drug manufacturing companies who have previously worked with international drug companies are currently in discussions to look at the feasibility and practicability of actually implementing this. But as Dr. Fiona said, these are not discussions that are completed in a matter of weeks or months, and we know that we do not have the credit of that time at the moment. We can see the evidence in what happened in Canada, who were also procuring vaccines and who probably have much more capacity to produce those vaccines if they wanted. And when their vaccines were also held up, just as with the COVAX facility, they indicated that they would have difficulty in starting in production of vaccines. It is therefore important to concentrate a lot on efficient distribution of vaccines and reducing vaccine hesitancy while we reduce the importation of new cases and new variants, because even though there is commitment at governmental level to produce vaccines locally, we do not expect that that should be able to happen before the end of this year at the earliest. Thank you.
Thank you, Dr. Kristen. The next question to you.
Yeah, thanks very much. Mary, I just want to say something about patent sharing, intellectual property and patent pooling, which is what WHO in the context of the ACT Accelerator and COVAX had been encouraging at the beginning of all these discussions, just to emphasize that, we may talk about local production, expanding production capacity. It is important that this information be shared between those who own the patents, those who have developed the products, and the potential producers. And this is a discussion that can go on at different levels, starting with at the World Trade Organization. I think you probably heard the Director General of the World Trade Organization engaging in discussions about encouraging this patent sharing and sharing of intellectual property, just to emphasize that it's not something that happens in theory. If we're really going to make real the issue of local production, expanding globally production capacity, this is one of the underpinnings of doing that. If somebody else is going to produce the product that you've developed somewhere, you will need to get into agreements, of course, with the local producers, the regulatory bodies, and the governments, as well as the private sector investors have to be engaged, and the pharmaceutical companies that own the patents have to be engaged in these discussions. It's very important as an underpinning of expanding manufacturing capacity.
Thank you, Dr. Moeti. The next question is coming back to you also. This is from Malawi Broadcasting. Most African countries, including Malawi, are using AstraZeneca, which most people are saying is less effective. We have countries like South Africa, which abandoned the process of administering AstraZeneca at the 11th hour, a development which made most African countries believe the vaccine is useless. What are the views of WHO and any assurance?
Okay, WHO's views are that this vaccine is not at all useless. And it is the vaccine that is the mainstay of the supplies that the COVAX has been targeting. Of course, we're looking at a range of vaccines. The South African situation is very specific. It's related to evidence that emerged from a very small study that we have to emphasize that the efficacy of the AstraZeneca vaccine against the variant that is widely circulating in South Africa is lower in terms of preventing, if you like, less dangerous versions of the disease. So we are now supporting countries, and it's true that this triggered concern by many countries where this variant is circulating, particularly some of the neighboring countries in South Africa, and quite a lot of hesitation to use AstraZeneca vaccine. We are supporting the countries to expand their ability to know if this variant is circulating or not. We are helping with genomic sequencing, working with the Africa CDC, so that countries can have a good idea of what is the variant that is circulating and whether the AstraZeneca vaccine will be effective. We emphasize that it is effective against severe forms of the disease. And I think the evidence given by our colleague from Ghana in terms of their experience there has also been extremely encouraging. So I'd like to emphasize again, it's not that the efficacy of this vaccine is so low that it is not useful. It is that there is a particular issue with a variant that has been identified, and work is going on to make sure that we help countries to use this vaccine where this variant is not dominant. In South Africa, it is dominant, and that is the reason why the government then decided not to use the AstraZeneca vaccine.
Thank you, Dr. Moeti. And to you, Dr. Ngoy, do you foresee the continent flattening the curve soon? And what are the risks ahead? This is from Naftali from Denmark.
Thank you, Mary. Just reading the curve of the pandemic in the Africa region, what you observe in many countries is actually up and down curve, which we are still experiencing in many of our countries. So the virus is here, and as long as the pattern of our social behavior remain the same, I believe we are going to see the same kind of pattern in terms of the curve of the pandemic. Maybe just to say that we were expecting, at least in terms of the impact on mortality, that the vaccine will have an impact, but now with this delay, we might have even that impact may be taken away. So the future again, it lies really on what us as African and communities we are going to behave. if we continue to ignore the public health measures, including social physical distancing, then most likely we'll have this up and down type of curve in our countries.
Thank you, Dr. Ngoy. So we are coming to the end of this first briefing. We'll be turning to our panelists. I will start with Dr. Ramaiya, then Dr. Kristen, and finally Dr. Moeti to give us their final thoughts. Dr. Ramaiya, please.
Yeah, thank you very much. I think most of the questions have been related to vaccines, vaccine coverage, vaccine penetration within the countries in the African region, and how can we effectively basically facilitate vaccine uptake within the region. I think looking from the clinical point of view or from a clinician point of view, I feel what is happening in India, probably I think one advantage we have in the African region is that the public sector infrastructure has been adequately developed, while in India, what I see from the clinical point of view was that it was the private and the corporate hospitals, which were basically the emphasis of most of the people. And with the current pandemic, which is there in place, the public sector has not been able to cope up because the infrastructure was not there. And I think what advantage we have here is that we have emphasized on the public sector, and that public sector, we need to strengthen it further because that is going to save our people at the end of the day. Thank you very much.
Thank you, Dr. Ramaiya. Dr. Kristen?
Thank you very much. So it is important to continue to emphasize that as we continue to basically follow the public health protocols, encourage procurement and administration of vaccines, that we continue to prepare for those who would be infected and who would have severe and critical diseases, as well as its impact on our health system for treatment of other diseases, which is now basically at its weakest. It is important to continue to strengthen our acute care delivery for both COVID-19 and non-COVID-19 related diseases. And this should be the foundation to basically prepare for years ahead while we're doing this. This disease will not be the last. We find ourselves in this position because this had not been addressed previously. We should take advantage of this to basically prepare properly and address the foundations of this problem in African countries. If not, we'll still be back to the same place. The cooperation between African countries, WHO and other agencies has been shown to be very important during this pandemic. We need to continue to strengthen those relationships, both in clinical management and in research, and making sure that these researches impact on our continent. Thank you.
Thank you. And talk to you.
Yes, I'd like to first just note that this is a difficult moment in the evolution of the vaccination programs in Africa. But I think that it should not throw us into despair. One, it gives us perhaps a chance to refine even further our planning and our preparation, learn from the experience that we've had with the first doses that were administered in Africa, and therefore be in a position to do a better job, a more effective job, more effective coverage of the target populations when we get the vaccine supplies. And then secondly, as I said, we've noticed that the rate of testing in our countries has gone down in quite a few countries. And so we need to re-engage on those public health measures that have been so good for us in Africa, so that the situation we had projected at the beginning of the pandemic did not happen. So the testing needs to be scaled up again. Contact tracing needs to be sustained. Isolating those who might infect others needs to happen. And as I've said before, all of us at the community level, as individuals, in our families, need to do our part to wear our masks, wear them correctly, remind our neighbors, remind our loved ones, support each other, and keep up the prevention measures while we look at the possibilities of the vaccines and the work goes to roll out the vaccines.
Thank you very much, Dr. Moeti. We have come to the end of the briefing for today. A very big thank you to our great panelists and all journalists. Thank you and have a great day.